much. May we then move on to item 6 on the agenda, which is around creating a genomic medicine service. If I could invite Professor Sue Hill, who's our Chief Scientific Officer, to join us. But I'm going to invite Bruce to introduce the paper, and then Sue perhaps to speak to it in more depth. But Bruce, please, can we start with you?
Thanks very much, Chairman. This would be the third time, I think, that we've brought a discussion of genomics to the board. And one of our roles, I think, as a board is to deal with the problems of today with an eye to the future. And it seems to me that there are 3 technologies that are going to have a really big impact on the practice of medicine or healthcare in its broadest sense over the course of the next decade: mobile technology, artificial intelligence, and genomics. And X-rays enabled us to see inside the body, a microscope enabled us to see inside cells. Genomics enables us to understand how cells work and to understand the basis of many inherited and non-communicable diseases. And one thing that's absolutely clear is that we lead the world in this sort of science. Indeed, life sciences are a key plank of the emerging industrial strategy for the government. So it makes sense that we should bring this expertise to our patients through application where possible in the National Health Service. And if we look at genomics and the sequencing of the human genome, it originally took 10 years and cost about $3 billion. Now it's down to under 24 hours and about 300 quid. So the falling cost starts to make this a realistic possibility after a number of false dawns. So Sue is going to outline some of our, at a very high level, our emerging thoughts and strategy as to how we might start to bring the benefits of genomics into the National Health Service.
Thank you very much, Bruce, and Chair, thank you. The board paper sets out an ambitious future vision for the NHS to fully embed genomics and other next-generation diagnostics into routine care. And as Bruce has already outlined, aligned with the government aspirations to build research and industry collaborations with the NHS in the life sciences sector. The proposed genomic medicine service and operating model outlined in the board paper builds upon both the long history in the UK of scientific advances in the field of genetics and genomics, and on the investment in NHS genetic testing services for now over 50 years. The NHS occupies a unique position as an integrated health system with access to longitudinal records, both important to the uptake of genomic technologies. And now is the time to capitalise on this unique position to take a step change in the uptake of genomic technologies, coupled with other technological advances, for example, in digital imaging and in data analytics. Although the NHS can currently test for over 4,800 genes in a variety of different ways and often in a set of series of tests for patients, the use of whole genome sequencing enables all the letters in an individual's genetic code to be determined in one test, enabling potentially important genetic alterations to be identified above and beyond those that we can test for now. The adoption of this technology into the NHS would enable some of the current testing undertaken in the NHS to be replaced and a greater diagnostic yield to be delivered with greater efficiency and lower cost. And in terms of that greater diagnostic yield, that can be between 25 and 50% enhancements to diagnosis depending on the condition. The major catalyst for the approach that we outline has come from the world-leading 100,000 Genomes project, which is sequencing whole genomes in participants with rare disease and inherited disease and cancer. The transformational change required to deliver an overall genomic medicine service that we set out in the board paper is already well underway through the work of the 13 NHS genomic medicine centres, established by NHS England to deliver the 90,000 sample commitment to the 100,000 Genomes project. Through these established partnerships and infrastructure, they have created across populations of between 3 to 5 million, the genomic medicine centres are providing opportunities for other significant service changes. While some challenges with the delivery of the 100,000 Genomes project remain, particularly around cancer, significant progress is being made, and the NHS has established world-leading pathways and protocols to get the most out of whole genome sequencing for participants. Cancer alliances and vanguards are important in supporting these and other initiatives to improve recruitment, but also to enable genomic pathways of cancer care for the future. The use of whole genome sequencing in the project is already delivering benefits to the NHS and informing the way it will be utilised in the future as part of a comprehensive genomic testing approach. For patients and their families, the project is already providing enhanced diagnoses, delivering improvement in outcomes through more targeted treatments, and enabling patients to enter clinical trials that they would not have otherwise been able to do. It will also help to optimise medicine for the future and reduce adverse drug reactions that are a significant cause, for example, of hospital admissions. As we move forward with establishing a genomic medicine service through to 2021, the continued partnership with Genomics England remains a critical part of the operating model. This will build upon the considerable expertise they have developed in the area of whole genome sequencing and analytical platforms, and how they can bring about a semi-automated interpretation pipeline, but also in continuing to develop the UK genomic knowledge database, which is important if we're going to continually deliver enhanced diagnoses for patients. To take this forward now, we need to begin the reprocurement of the existing genetic laboratories in the NHS into a consolidated genomic laboratory hub network that's coordinated and underpinned by a comprehensive genomic testing strategy for rare and inherited disease and cancer, and through the alignment with the commissioning system from CCGs, and importantly with specialised commissioning, but also being embedded in STP plans. This is on the basis of securing whole genome sequence provision to become operational in the second half of 2018-19 and delivered as part of the genomic testing repertoire that will be available in the NHS. If the board is content to approve the high-level approach set out in this paper, we will develop our detailed implementation plans and the business case to make this ambitious vision a reality. Thank you.
Let's invite some comments, queries from members of the board. John Byrne.
A great privilege and pleasure to be a member of your team, so I actually know more about the detail of this, but I'd like to just, as a board member, raise the issue of cost and benefit at the higher level. Clearly I'm an equipoise between the benefits as an academic geneticist and keen to see this happen, and yet the costs as a member of the workforce and as a member of SpecCom that somebody has to pay for it. So the two sort of questions that are in my mind is, the first is, as we move towards a more integrated genomic medicine service, are you comfortable that we can control activity? Because clearly my experience in my lifetime is once people get an idea for a new test, everyone wants to order it. So as we spread this out, how do we manage that activity so that we actually do the tests effectively, which flips over onto the workforce in terms of the impact on the workforce being expected to deliver that, and perhaps also the existing budget being expected to carry it rather than it being seen as a new development. So how do you feel we're going to cope with that?
If I may. In terms of activity, John, you're absolutely right. What underpins the introduction of a comprehensive genomic testing strategy is a clear and coherent order communication system, which means the way in which tests can be ordered will be set out for different conditions, and the type of test that will be applied for different conditions will be based on evidence, and evidence for the utility, either in terms of the utility that we can get from whole genome sequencing against the cost, or for doing a single gene test because it's relatively cheap to do and provides all the information that's necessary for that condition. A critical part of going forward and outlined in this paper is the need for there to be coordination of the laboratory hubs infrastructure that will be created, such that the activity is clearly monitored and managed, and the advice that's provided to the commissioning system really drives what those hubs are able to order and provide for their populations in the future. The second point you make is around the impact on the workforce. What we know with a whole genome sequence provider being outside of the NHS delivery chain, that this will require a new cadre of expertise in the NHS to interpret whole genome sequence data. So part of the strategy will be to develop the workforce to undertake that type and have that type of expertise, as well as thinking about what will remain in the NHS to be delivered and how efficiently that can be delivered by an appropriate matching of skill mix.
And then Noel.
Thank you very much. Sue, as well as being very excited by the potential of this technology, which we are, as a board we obviously have to be mindful of the scale of investment required and the financial consequences of the decisions that we make. So what I'd like to ask is that in the business case you bring forward, could we please look at, under the umbrella of the overall strategic approach, what the options are and what the financial consequences would be of those choices?
Yes, I think that's a very good suggestion, and I think to reassure board members, the economic modelling that will underpin the business case is being done in conjunction with health economists at Oxford University and very much informed by evidence that we're gathering from across the world.
Thank you.
No.
So the value of the genomics programme in terms of paving the way for personalised medicine is very clear. But we also, in a sense, have a national asset that we're developing here in the context of the bigger life sciences industrial strategy, because it has the potential to attract pharma, attract research, speed up trials, help us with the medtech sector as well. Could you just say a little bit about how, as you evolve the genomics asset, you are thinking about its role in terms of supporting a much more vibrant life sciences business economy in the UK?
So if I may use the example of what's happening currently in the 100,000 Genomes project and ongoing dialogue with the NHS, that may illustrate, but I think there's a broader question that I would defer to Simon to answer about the more strategic positioning of the NHS with the life sciences sector and the way that will be taken forward. But within the 100,000 Genomes project, through obtaining participant consent for the use of their de-identified data to enter in to what is becoming a UK genomic knowledge database, we're starting to understand how that can be interrogated by researchers across the world. So to start to align the research questions with the research funders, and secondly, in an international effort often, and secondly, how through a pre-competitive consortium of industry players, the value of that data and how that data can be enhanced, really to start to think about how the NHS and real-world data could be utilised to drive clinical trials in a different way. I think part of the work going forward in genomics is how we as NHS England can enter into a new dialogue with industry who are interested in doing clinical trials in this area, and what the NHS can benefit from that collaboration.
I think it's important to note also that with GEL, we've had a bridge to industry. It's been quite important to have a company that's separate from us and separate from the Department of Health, but which can also release data that's of value to industry on an anonymised basis. And part of the business case for the future is going to need to consider how we maintain these relationships and how we maintain the other benefits that GEL has brought to the system as a whole, particularly around data curation, which is of great importance to us. And I think Noel, with future relationships with NHS Digital, is taking on many of those responsibilities. So there's actually quite a complex transitional process as we go through what is currently pretty much the proof of concept, which is the 100,000 genomes. We know we've got that, I think, now reasonably well established with rare diseases, a bit more difficult still with cancer for a number of reasons that Sue outlines. But then into, I suppose, initial phases of transfer into the clinic more generally, before the full rollout. And that transitional process will also include further work on cancer, so that we can bring it up to a level where it will be capable of bearing the clinical weight that we'll ultimately have to do. David.
Sue, just an observation that this all sounds hugely interesting and exciting, and as Bruce said, is a next sort of wave of clinical activity which opens up sort of things we've never even dreamt of. It also has a sort of a slightly scary connotation to it, or it could have, and quite a lot of misinformation about what this could say or could not do relative to insurance, relative to all sorts of aspects. And therefore, in the sort of the next discussion around the business case and the way, I'd encourage us to be thinking about what investment we need to be making in education and engagement with the with sort of citizens of the country, with our clinicians, to make sure that everyone understands what this really is and what its opportunities are, as opposed to what could be construed as being sort of quite somewhat threatening. So I think we need to think of the human dynamic, not just the infrastructure and the science and the data. There's another big element to this that's very important.
Thank you, David. I think that's a very good point. In your note in the board paper, we did outline some of the public and patient engagement work that's happened to date, and that's been an integral part of each of our 13 genomic medicine centres from the very start. And they have very active groups that are participating. But this is the start of a conversation with the public, especially as we use genomics to really drive our personalised medicine approaches, and where there will be, in some instances, on the basis of any genomic mutation that's identified, a certain set of treatments may be inappropriate for patients. So it's a different conversation, and one that we need to build in. And secondly, the clinical change model that you allude to, from primary care right up to secondary and tertiary care, is an important dynamic here. And part of the work going forward is to work closely with the Academy of Medical Royal Colleges, but also with all the professional groups, with the Royal College of Nursing and Midwifery, as well as the whole multi-professional team that will be critical in delivering this.
Primary interface, as always, will be the vital services of our GPs and our nurses and the practice supports, and how we equip them to have good conversations and support that is critical, I think.
And David, if I may just come back to you, earlier this week we had a conversation with a set of interested professionals around familial hypercholesterolemia testing, which can be in terms of understanding and determining individuals' genotype. That's really important in either starting treatment earlier or starting new types of treatment. And what was interesting is a lot of the conversation was how we could ensure that primary care had access to those type of tests that will be built into our comprehensive genomic testing strategy for the future.
Thank you.
Victor?
In relation to that, I'm just curious about how this relates to inequalities in the inverse care law, and how this whole programme helps to close the gap.
Yeah. So thank you, Victor, for asking that question, because some of the current genetic testing in the NHS at the moment does not reach all the parts of the population it needs to. And because there's no overarching coordination of the provision, then we've had no way in the past of either aligning the commissioning system with that or really ensuring that locally there is a focus in those clinical specialties where the patients would benefit. So I think this is a clear part of the overall strategy that we outline here. Is to start to address the inequalities. What's been interesting as part of the NHS contribution to the 100,000 Genomes project is we're starting to see previously unknown rare disease presenting into the project, rather than what's been known, but there's just been no diagnosis. So I think it's starting to happen, but we have to help to ensure that this is part of our systematic embedding in the future.
Its impact in that regard.
We're starting to measure that. It's quite difficult to measure because it's actually never been looked for in any detail before. But we're certainly measuring the equitable access to the 100,000 Genomes project and using that to drive our strategic approach to reducing inequalities in the future.
Wendy.
Yeah. I've been incredibly impressed with some of the early results coming out of Birmingham to see some of these things already feeding into our medical processes, and that's incredibly exciting. As a typical patient consumer, when would I expect to have a conversation with my GP about this or in the medical system? For an everyday person, when is this a reasonable dream?
So at the moment, obviously, the access and the to either the project or to existing genetic testing is very focused and polarised. So the more systematic access will start over the next 3 years, but will take us probably a 10-year journey to get there in totality. But what's important with this is to start to engage early with general practice. And it just so happens later today I've got a meeting with the Royal College of General Practice to start to begin that conversation or to take forward further conversations with them about engaging family practitioners. But what's happened, I think, over the last 2 to 3 years since we've been working on this project is there is a greater awareness within the NHS of this, but there's more that we need to do. But it will be between that 3 to 10 year journey before this will be available.
I think we're in the foothills of it, Wendy. So at the moment, if in your family there are people with certain types of genetic anomalies, you'll get access to it. If you have certain types of cancer, you may get access to it. But that's just the beginning, because we don't even know necessarily exactly where this is going to take us. But we're clear that it's going to take us into a much deeper understanding of disease and provide opportunities for new treatments.
Right, well, thank you very much, Sue, for the paper and for the presentation. I think you can take it from what you've heard around the boardroom table, A, that the board notes what's been what's been developing under the 100,000 Genomes programme, B, I think is warmly endorsing the high-level strategy, but C, with still a recognition that there are many as yet unresolved issues and many variables to be addressed in bringing this programme more firmly into the clinic. Over the next 2 years, which are, as I was saying before, very much a transition period, there's a lot of issues that we're going to have to sort out. So with the volume and with the funding and with the distribution, I think to Victor's point, the setting up of 13 GMCs across the country has been a fundamental element of securing equity of access to the technology across the country. And that's something that we need to continue to embed. I think the final point, though, is that this is an area in which we are currently the world leader. And I would be very keen to ensure that we did everything possible to maintain that leadership and to be the country from which other people bought the ideas and the technology rather than the country that ends up buying it from somewhere else for having been falling behind the path that we need to go on. So we will be coming back to this over the next year or two because of such fundamental importance to the future of diagnostics and therapeutics in the NHS. But thank you very much, Sue, for bringing us up to date, and we look forward to following further developments with enthusiasm. Thank you.